Alrighty. Hi, everybody. My name is Erin Warren, and I am the undergraduate academic advisor for the Global Health Program here at UCSD. I wanted to say thank you so much for attending the 2022 Horizons of Global Health Research Symposium. We're so excited to honor our students and also celebrate the amazing work being done on our campus in the field of global health, as well as to honor the lifelong achievements of Dr. Paul Farmer. Please note that this event will be recorded and posted online on the Global Health Program event page, as well as our YouTube page. So before we begin, we wanted to highlight some upcoming Global Health Program events and application deadlines. First, we have Students for Global Health, General Board Meeting number 2. This is going to be tomorrow, May 12th at 7 p.m. via Zoom. And the topic for this meeting is careers in global health. So come hear from Global Health alumni and where their career paths have brought them to, hear a little bit more from them. Next, we have Students for Global Health's Blue Bowls fundraiser. Join the Students for Global Health for a fundraiser at Blue Bowl tomorrow, Thursday, May 12th. The fundraiser is going to last all day from 9 a.m. to 6 p.m. and we'll be attaching the flyer in the chat. So you'll want to show this at checkout to participate. And 10% of all bowl sales will go to the Karen Organization of San Diego, which supports refugees from Burma living in San Diego. So definitely come on down on campus and come meet some other global health students and support for a great cause. Next, we wanted to highlight the Global Health Institute's A Challenge to Dignity conference recordings. This is a conference on the health and well-being of refugees, asylum seekers, and forcibly displaced people, which took place in the fall of 2021 with a panel of experts. The recordings of speaker presentations are now available on the GHP YouTube page and events page under past events. So definitely go ahead and check those out. There's a lot of great speakers and a lot of great content. And lastly, if you are a rising senior and you want to take part in the Honors Thesis program, maybe you're inspired by some of the presentations today, the 2023 Honors Thesis Cohort application will be opening very soon. More information will be sent out this week and in next week's Global Health News Blast, so stay tuned for details. And just so that you have it on your calendars, this will be due June 12th at 11:59 p.m. Again, we'll be sending out more information in the news blast. You can also visit our Instagram page for everything that's going on in the Global Health program. Additionally, for those in global health courses that are receiving extra credit, there will be an online sign-up sheet posted in the chat towards the end of the event. So be sure to look for that as well if you're in a class that is receiving extra credit. Lastly, I wanted to give a big thank you to our Global Health Program student representatives, Renak, Colette, Jonathan, Sarah, Mitchell, and Lita, for all of their work in putting on events and planning programs and also tabling at campus events. It has been so fun working with you all over the last year and some of you over the last 2 years. And we recognize the leadership that you represent to our community of students, especially with the ongoing challenges of being in person, going remote, going hybrid, being back in person mostly again. So just wanted to give a big thank you to you all, and I'm excited for all of the things that you get to do next. And now it is my pleasure to introduce this afternoon's MC, the Global Health Program Director, Dr. Thomas Shordash.
Greetings, everyone. I'm Professor Tom Shordash. Welcome to the 2022 edition of Horizons of Global Health Research Symposium. Horizons is an annual event at UC San Diego made possible by the Global Health Program in collaboration with our faculty, staff, and student leaders. As with all our events, our goal is to bring the global health community and the local San Diego community together to discuss important issues in the field, but also to celebrate the work being done in our community. Though we are forced into the technological solution provided by Zoom and can't be with one another in 3 dimensions, We also have to acknowledge the unintended benefit of being able to reach a much wider audience than with our usual live events. Before we begin, let me express special thanks to our co-sponsors and individuals who have made these events possible this year. On behalf of the Global Health Program, we'd like to thank the Global Health Institute, the Center for Global Mental Health, and the Eugene M. Burke Lectureship for providing support and sponsoring this event. Additionally, we'd like to thank Aya Healthcare for their generous support and sponsorship of this event and other global health programming. Next, we'd like to thank our global health student leaders in Students for Global Health organization and our global health student representatives for the work that they've accomplished throughout the last academic year. Finally, we would like to especially thank our Global Health Advisor, Erin Warren, and our program coordinator, Brittany Wright, who contributed to putting together this afternoon's event. Given the extra challenges, technological and logistical, I want to make certain we give abundant thanks to Brittany and Erin, and not only for this event, but for everything they do for the program throughout the year. As I mentioned, one of our event sponsors is Aya Healthcare, and we're very grateful to be continually partnering with them on new initiatives. The team at Aya wants to share their congratulations to our students and also recognize our Aya Scholar winners.
Congratulations to students and faculty on finishing your school year. At Aya Healthcare, we're proud to support the Global Health Program and all of the amazing work you do. We're especially proud of our Aya Scholars. We wish you the best of luck on your field experiences, where you'll not only help communities in need, but also learn and grow. We're excited to see the impact you make on the future of global healthcare. And we're extending the deadline to apply.
For any students interested in support in field experience funding and support, we encourage you to apply for this generous award for your work, the Aya Scholars Program, and you can find the link in your chat. We also want to thank the Eugene M. Burke Lectureship for co-sponsoring today's event. The Burke Lectureship on Religion and Society sponsors public lectures in which scholars, theologians, and religious practitioners address critical issues on the relationship between religion and society and on the religious dimensions of being human. The Burke Lecture was sponsors of an intended lecture by Dr. Paul Farmer, planned and rescheduled for this month, which had to be canceled due to his unexpected passing. But they wanted to join the Global Health Program in honoring his legacy at this special edition of our Horizons of Global Health Research Symposium. We'd now like to recognize the hard work of the 15 Global Health Honors Thesis students in our 2022 cohort, our second honors cohort in the program. This 2-quarter-long program provides students an opportunity to expand, deepen, and share the insights of their global health field experience or a topic of interest in the field of global health with members of the cohort. These students have participated in intensive reading, discussion in fields related to each student's primary interest, and in preparing a senior thesis project and a poster that will provide an important credential for these students, an item on their resume in the next stage of their careers. Pre-pandemic, the Global Health Program would host the Horizons of Global Health Research Symposium event in person, featuring an undergraduate research poster session and a keynote speaker. Though this year's symposium event is virtual, we're looking forward to this year's installment of the virtual Horizons of Global Health Research Symposium poster session on our Global Health blog, which has been shared in the chat. We also want to highlight the honors students and share a few examples of their excellent research as presented in their posters and their theses. Please visit the Virtual Horizons site to view the important research being done by our students. The honors program had two cohorts of students this year, or two groups of students in this year's cohort, I should say. And I'd like now first to invite honors cohort instructor Hua Wu, who everyone knows as Miranda, to share a few words about her cohort. Miranda?
Hi, thank you, Tom, and hello, everybody. It's my honor to be here and to share with you guys my understanding and my experience of leading this cohort. As an instructor and leader of our cohort, it probably is biased of me to say our students have been the best that I witnessed in all my life here at UCSC, not only because they demonstrate excellent research skills, but also I think most importantly, the commitment, passion, and hope for representing a very excellent group of global health program, because they care so much about a diversity of research questions and issues closely connected to human experience and to health. And it has been a very difficult past few years with the global pandemic and a lot of ongoing social injustice that's been going on in the world. But I think my students and our students, our cohort, their research and their potential is giving me a lot of hope personally as well. So without further ado, I want to take you to my cohort. We have Stephanie Alfonso, and she's writing about the forgotten ones, the painstaking truth of COVID within the world of Alcoholics Anonymous echoes relapse. And Lance Capsule, the envisioning a different Veterans Health Administration recommendations for timely post-traumatic stress disorder care for veterans. We have Zuri, and her topic is on provider health literacy impact on non-binary and transgender young adult care. And Colette, addressing gender-based violence against Rohingya refugee women through inclusive WASH. We have Genevieve, the role of frontier culture and rugged individualism during the US COVID-19 pandemic response, and Yasmin for making better decisions in the cancer care of Hispanic Latina immigrants. And we have Jackie, bringing to us the non-communicable disease among Syrian refugees in neighboring host countries, and Casey, reproductive injustice at the US-Mexico border, how systematic harm continuously affect migrant and undocumented women with lack of prenatal and maternal care. So these are, as you can see, very interesting, very diverse, and very important research questions, and you can check our website for all their presentations being recorded and uploaded on YouTube video. And next, let me introduce Giselle Sanchez for her group of students.
Thank you, Miranda. Hello, everyone. I am very pleased to recognize the tremendous accomplishments of my honors thesis cohort. In particular, I would like to speak on several points of accomplishment worthy of recognition. One is the level of academic rigor that my students have demonstrated. For the past 5 months, they have learned to develop a research question, conduct literature searches, synthesize a tremendous amount of academic articles, and ultimately produce a written research paper. As if this were not challenging enough, troubling national and global events have unfolded over the duration of this course, which brings me to the second point that I would like to honor. So rather than working through adversity, my students have engaged with and even challenged dimensions of social, cultural, and political conditions that we face as a nation and on a global scale in their respective research projects. I find that the research topics that my students investigated, as well as their suggestions for future directions in research, offer hope for what's to come in global health, social justice, and beyond. I'm also heartened to say that these projects would make Dr. Paul Farmer very proud. Thank you for all the care and all the thought that you have all put into your thesis papers, and I cannot wait to hear what you all accomplish in your careers. So with that said, I have the honor of reading my students' paper titles, which certainly convey to the audience how salient and timely these projects are. So first we have the Faces of ACEs, evaluating the effectiveness of ACE measurement scales for US immigrant youth by Vivian Chang. We also have A Pandemic of Unequal Proportions, SARS-CoV-2 presents inequality in facets of vaccination, a non-systematic review by Keyvan Dzechi. Sociostructural factors influencing women's decisions about birthplace in the US by Lucia Ferrer. Contesting mental health stigma as a transparent barrier to healthcare within US Chinese immigrant communities by Lena Lee. Why we need to say gay, an evaluation of the efficacy of psychotherapeutic interventions for LGBTQ youth in the United States by Kira Woodland. Painting the Full Picture, HIV risk groups and barriers to care within Tijuana by Brent Siegel. HIV and syndemic vulnerability, approaching the epidemic holistically across Indonesia, Vietnam, and the Philippines by John Ray Peneliar. And now I have the honor of introducing Lucia Ferrer, who will be giving us a brief overview of her research project. So Lucia.
Thank you, Professor Sanchez, for the introduction. I'm going to share my screen. So as Professor Sanchez mentioned, my name is Lucia Ferrer. I'm a fourth-year undergrad in the Global Health program. And my research interests and what I'll be talking about today include the medicalization of childbirth and how that process has affected where women decide to give birth in the United States. So as a little bit of a background, previous literature has included either quantitative analyses of birth data or qualitative measures of individuals involved in the birth process, but few have integrated both to examine how they combine to produce the effects on we see on childbirth today, despite no decision anyone makes being purely quantitative or qualitative. So today in the United States, the majority of births occur in the hospital to the tune of nearly 99%. Despite having equal or safer outcomes at home in a planned home birth. Hospitals have much higher rates of labor interventions in planned home births, as you can see in the graph here in the middle. The green is planned home births and the blue is hospital births. And little power is granted to pregnant women. So as an example, one of the most common labor interventions is a cesarean section. The WHO and the CDC both recommend the C-section rate be between 10 and 15%, as maternal and infant mortality rates increase when C-sections surpass this threshold. However, in the United States, the C-section rate is nearly 32%, which clearly exceeds these guidelines. So I think this poses two questions. One, why do we continue to regard biomedical institutions as the epitome of safety? And second, are there groups for whom the success of hospitals is favorable, private health insurance companies or doctors working under a fee-for-service payment model? And to answer these questions, I've identified 4 conditions that I think shape maternal health care in the United States. So there are these 4 conditions here, and I'll go through each one and give a little bit of an example of each. So the first is healthcare structures. The United States spends more than any industrialized country on healthcare, but has the highest rates of both infant and maternal mortality. So the graph below also shows that births in hospitals bring in incredible revenue for these hospitals compared to planned home births. And this is both a national average and a California state average. Second is medical and bodily autonomy. Anecdotal evidence shows that women's rights to informed consent are routinely ignored during childbirth. And third is safety and risk perception. So while cultural factors play a role in these decisions about where women decide they will give birth, safety is often at the forefront of mothers' minds when deciding to give birth in a hospital and at home. I think there's often a misconception that women who decide to give birth at home aren't concerned with safety, but various studies have shown that women perceive a home birth as safe and safer than a hospital, which based on this graph above is true. And last is racial disparities. So people of color receive worse care than white populations in 35 to 40% of healthcare quality measures. And this extends to the obstetric field as well. The infant mortality rate is highest among Black infants, and that rate is over 2 times higher than the infant mortality rate for white infants. So these 4 structures become embodied in a woman's worldview and influence and obscure her decision about where she can give birth. She's limited by things like what setting will her insurance cover? Will her physician respect her right to accept or turn down procedures? What aspects of her birth will be accepted by her insurance if the setting she chooses is accepted? And I think more broadly, what can this tell us about our own say in our healthcare, not just in the obstetric field, but in any field, and 2, the transparency of medical practitioners with their patients. Thank you.
So Miranda, to introduce Colette.
Hi, and everybody, we can have the honor of bringing Colette. Please bring your research on the WASH, a Rohingya refugee and WASH.
Okay, great. Thank you, Miranda. Let me know if you can see this all right. Does that look okay? Okay, awesome. Hi, everyone. My name is Colette. I'm a 4th-year double majoring in global health and communication, and my research interests include refugee health and women's health. And so my project specifically focuses on addressing gender-based violence through water, sanitation, and hygiene, also known as WASH, for a specific group of refugee women known as the Rohingya from Myanmar. And so in 2017, after a wave of ethnic cleansing in Myanmar, humanitarian agencies rushed to set up emergency WASH services, but it's estimated today that Rohingya women still face high rates of WASH-related gender-based violence, and only 30% of Rohingya have access to adequate WASH. And so my research question asks, in what ways does inadequate WASH contribute to gender-based violence for Rohingya refugees, and how can WASH practitioners implement more inclusive WASH? And so after analyzing the existing literature on the current WASH interventions, I found that the main reasons why gender-based violence was being worsened was due to poor planning, as well as lack of consideration for the specific vulnerabilities and needs of Rohingya women. So for example, bathing and latrine facilities were located too far away from living quarters, and they also often lacked privacy and locks. And this resulted in women being sexually and physically assaulted while they were walking to the facilities, as well as using them. Additionally, Rohingya women are the primary collectors of water in their community, but again, the water collection points were located too far away, and the lines were too long for waiting. So women were assaulted while they were walking to collect water, as well as waiting in these lines. Menstrual hygiene was also an issue with regards to privacy and waste management disposal. So I found that a lot of women were waiting until nighttime to privately dispose of their waste, but this was also dangerous and led to them being attacked. And so even though there's scholarly consensus surrounding the idea that including women in multiple phases of WASH planning increases sustainability and decreases gender-based violence, I found that there were no current Rohingya WASH interventions that included women in multiple phases. And so I argue that by including women in planning, education, and leadership phases of WASH, we can create more sustainable WASH and therefore reduce gender-based violence. So I created my own WASH intervention guiding framework, as you can see on my poster, and this includes how to work with women at each of these 3 phases. This includes things like consultation interviews, WASH literacy programs, and the creation of gender-balanced WASH committees. It's my hope that this framework is applicable to Rohingya refugees as well as future refugee groups, and it's increasingly important that we implement these sustainable and inclusive practices immediately, because with each year that refugee situations are protracted, humanitarian aid is decreased. I think that as one of the world's most vulnerable populations, refugee women deserve dignified access to WASH services that work to not only increase their health outcomes and improve them, but also to protect their safety. I think more broadly, my work speaks to the possibilities presented by the radical inclusion of women at all phases of health interventions, and that only by including, recognizing, consulting, and addressing the needs of our most vulnerable populations can we create truly equitable health outcomes. Thank you.
Super proud, love that project. And next we can have Genevieve on her topic on the role of frontier culture and rugged individualism during our COVID pandemic response in the US.
Great. Thank you so much, Miranda. Okay, hi everyone. My name is Genevieve and I'm a fourth year in the Global Health Honors Thesis program. The topic of my research and capstone project this year was the relationship between frontier culture and rugged individualism in the US and the role played by these ideologies during the public health response in the US to COVID. So living in a predominantly COVID-19 skeptical neighborhood over the course of the pandemic kind of piqued my interest into the cultural and sociological backgrounds of these beliefs. And so in my research, I decided to explore the relationship between individualism and the influence that this culture kind of had on the US public health response, as well as the population response to public health mandates that were enforced during the pandemic. I argued that the ideology of rugged individualism, which fosters self-reliance, independence, and kind of anti-government attitudes, was largely responsible for the state of the US COVID-19 response, specifically when considering the lack of collective action and resistance to preventative behaviors like mask wearing and vaccinations. My methods included using a literature review to look at the different aspects of this relationship to form a kind of roadmap of connections between frontier culture, individualism, and the US health response. I focused specifically on the link between frontier culture, which was the culture of independence which developed on the American frontier during the westward expansion, and how that played into the formation of rugged individualism in the US. I also looked at the definitions of individualism in the context of public health, concepts of cultural tightness and looseness, which kind of defined the structure of a society and how that related to public health, as well as health differences between countries with civic cultures versus countries with individualistic cultures. And finally, I tried to connect all of these to figure out the role played by individualism on public health responses in the US, which is kind of visible in the figures on the screen in front of you. Figure 1 shows the places in the US with the most frontier culture and individualism-driven culture, while figure 2 on the right shows the level of COVID transmission during the Delta variant wave of the virus. So research into this field is pretty important when analyzing and comparing differences in COVID-19 health responses across the world, as cultural differences play a crucial role in health behaviors. The importance of culture was brought to light during the pandemic, highlighting its importance in public health and the need for further research into the effect of these differences on infectious disease spread. This issue is commonly looked at from a biological, political, and economic lens, but is rarely considered using a sociological perspective, which is crucial when considering the role that they play in health behaviors and health promotion. Looking at how the response changes with culture is also important for planning for future disease outbreaks, and analyzing these differences can better help organizations prepare and equip the populations to handle future disease spread. Thank you so much.
And next we have Jackie presenting to us. Her research topic is on the, sorry, my screen just glitched. Her research topic is on a non-communicable disease among Syrian refugees in neighboring host countries.
All right, can you guys all see my screen? All right. Hi, my name is Jacqueline Samaha, and I am a fourth year global health major at UCSD. And my research focuses on non-communicable diseases, or NCDs, among Syrian refugees living in neighboring host countries. So the Syrian conflict began in 2011 and has led to the largest refugee crisis in our world today. And over 6 million refugees have fled Syria, and 95% of that population resides in the neighboring host countries of Lebanon, Turkey, and Jordan. So among the many challenges that Syrian refugees face in host countries, NCDs are highly prevalent and undertreated. And while it has been well established in literature that NCDs are undertreated among this population, not enough has been written about the structural and social factors that impact NCD outcomes. And furthermore, little to no research on this topic has taken a comparative approach to assess the similarities and differences between each host country. And so for this reason, my research provides a comparative analysis of the 3 major host countries because each country utilizes a different approach to the design, delivery, and funding of care. My findings indicate that Lebanon, Turkey, and Jordan differ in many ways, including their sources of healthcare for refugees, the cost of primary care, and in the existence of refugee camps, all of which lead to varying levels of NCD prevalence. For example, and as can be seen under findings here, Turkey provides the majority of its refugee healthcare from the AFAD, which is a Turkish governmental agency, while Lebanon and Jordan provide care through the United Nations Refugee Agency. And in addition to that, Turkey provides free primary care, whereas Lebanon and Jordan provide primary care at a subsidized rate. And the portion of Syrian refugees who live in formal refugee camps versus in host communities also differs between each country. And differences like these determine the accessibility, cost, and quality of NCD care, and they highlight the fact that a one-size-fits-all approach will not solve current health issues among this population in this region. Considerations of these differences are significant because they directly impact intervention design and the level of investments used to close gaps in NCD care. Future solutions must create more specific and tailored approaches to care to accommodate for the different healthcare systems, living circumstances, and costs. And lastly, this comparative approach is not limited to this population, as it may serve as a model for understanding the complex health circumstances of refugee populations all around the world. Thank you.
Thank you all very much, student presenters. This is just a sampling of our honors cohort thesis presentations. As we mentioned, all of the student elevator pitch style presentations are available to watch on the GHP YouTube page and on the Global Health blog. We want to express how proud we are of all of the honors cohort's accomplishments and fascinating research efforts over this past year, especially given the challenges of hybrid learning. We also want to take the opportunity to recognize our graduate students from our 3rd MA cohort who have submitted their video presentations of their master's theses. The MA in Global Health students have the option to complete a research-based Global Health master's thesis under the supervision of an affiliated faculty member in the program. And students who have submitted their thesis presentations can also be found on the Global Health blog. These 2 students are Emily Hardy and Gabriella Stone. Congratulations to Emily for her thesis project, Barriers and Facilitators to Substance Use Initiation for the Heroin-Based Drug Wonga, Thematic Review of Evidence from South Africa. And Gabriella Stone for her thesis project, examining the determinants of COVID-19 childhood vaccination decisions, the role of protective behaviors, adherence, and burnout. Finally, we want to recognize the MA academic coordinator, Dr. Seth Hanna, and MA advisor and program coordinator, Brittany Wright, for helping grow the MA in Global Health at UCSD into a thriving, well-recognized program, and for continually supporting and mentoring our students. Congratulations to all of the 2021-22 grad students. And now we'll transition to today's speakers. Our introduction to the keynote speaker will be given by Dr. Janice Jenkins. Professor Jenkins is a psychological and medical anthropologist. She received her PhD from UCLA and postdoctoral training at Harvard Medical School. She's been principal investigator for research on culture and mental health among adults and children in socioeconomically disadvantaged regions of Mexican, Salvadoran, and Puerto Rican, Latinx, Hispano, and First Nation populations in North and Central America. She leads research and intervention teams concerned with social and cultural processes that improve or exacerbate the course and outcome of illness, migrant health, and sites of care in Mexico and the US border region, and the central role of struggle in processes of living with conditions of mental illness and inequity as pressing matters of fundamental human rights and social justice. Her introduction is titled Paul Farmer as Life Force for the World, a Personal and Collective Engagement. And I regret to say that Professor Jenkins is ill today. So on her behalf, I will present her presentation. That is Dr. Paul Farmer in his office. And remember, these are the words of Professor Jenkins. Thinking about what I want to say for this annual Horizons event dedicated to Dr. Paul Farmer has been difficult. Of course, there is the immediacy of the recent loss and the fact that tomorrow, May 12th, was to be the third rescheduled date for his visit to UC San Diego, including a special seminar he and I were to do together for the Center for Global Mental Health. The first date we had set was March 12th, 2020. As we know, that was quite literally days before our first stay-at-home order. 2 days before Paul was to arrive, I sat in my living room with two very long to-do lists. One in the event that things went forward, one should things be canceled. That afternoon, I got the news that both UCSD and Harvard had canceled all non-essential travel for faculty and all campus events. We knew then that all the preparations we had made would have to roll over to another date. We had no idea that would take 2 years, given the ongoing pandemic, but we did reschedule for February 2022. Because in-person and larger events on campus were still not approved as of mid-January, we decided better to reschedule for May 12th, 2022. Needless to say, that was not to be. Here at UC San Diego, as faculty and students in the global health community, we're keenly aware of a shared foundation in the work of Dr. Farmer and colleagues. Our shared framework insists upon health as a fundamental human right with an emphasis on social justice. That moral compass directs our efforts to communities and regions under the press of intersecting realities of poverty, misogyny, racism. What Paul wrote about as structural violence that seriously limit or preclude care for life-threatening and life-diminishing health conditions. Professor Farmer's theoretical and ethnographic scholarship is meticulously crafted in numerous books and articles, warranting our thorough attention. Here are just a few of them. I'll let you soak in these titles. The compelling case for the intersection of health and adverse social conditions is made by many these days. So why and how is the work and life of Paul Farmer so vital and so generative for us? The way that I can respond to these questions is on the basis of knowing him myself for 35.5 years. What I can say is unequivocal. He stands out as utterly and indispensably important because his work, just as everything in his life, was personal, candid, and real. When you read journalist Tracy Kidder's well-known book, Mountains Behind Mountains, it's a particular read for someone such as myself who has the privilege of knowing Paul. It's filled with utterly mind-blowing stories about the lengths that Paul would go to get things done and to see patients. Unlike the vast majority of the mounds of works we read, the most striking thing in the book is this: it is all entirely true. This is why I think the book has been so transformative for so many students and the general public. It's not only about human health in all things that matter, it's also because the story rings really true. Paul was and is the real deal. Paul was always the first to say that his work was always and everywhere a collective. Over the decades, this evolved to an ever-expansive and bonded global weave of lives and works. Some of the early formative days for this weave were underway in 1986, when I first met Paul in Boston, when he, I, and several others, including GHP Director Tom Chordash, were together for 4 years in training at Harvard Medical School. The program brought together MD PhD students, mostly physician anthropologists, and postdoctoral trainees in medical and psychological anthropology, among others. Along with key faculty mentors at the time, I experienced this as an altogether electric group. It certainly is true that much work got done, and I don't think that Paul ever slept much, the last to leave and the first to arrive, which in retrospect could be accounted for because he slept on somebody's couch or in the coffee area of William James Hall. But the truth is, in the midst of this frenzied work, we also had fun. While I'm certain that nobody ever worked harder or longer than Paul did, he always did so with great humor. Paul's brilliance in nearly all things, connecting with people as many as he could, as often as he could, makes him a very powerful force. This is what I recognize as a life force, and this propelled him into and across any room he entered. So early on the morning of Monday, February 21st, 2022, when both Tom and I received telephone calls, me in New York on academic sabbatical, Tom here in San Diego, I have to say, I simply wailed and had difficulty walking across the street for a couple of days. I did manage to get on a train to Boston to be with friends in the shared crush of grief. We realized, however, that Paul lived and died doing what he loved most: teaching, working with patients, writing scholarly books and articles. There is so much in these that is a treasure chest for us, with roadmaps for connections with partners in health, including here at UCSD. There is much for us to continue to do engaged with the life force that is Paul Farmer. This is a photograph of the University of Global Health Equity and the trainees who are currently at this brand new facility. Paul was fond of saying that trainees were his retirement plan. Most recently, he was overjoyed that as of 2019, the University for Global Health Equity in a poor rural area of Butaro, Rwanda, had been launched in concert with a district hospital there that had opened up in 2011. To close, I'll leave you with a story. 4 days after Paul died, we had 3 hours of shared memories with friends and colleagues online. After that event, Paul's chief of staff, Katie Kravlitz, sent us an email along with a photo she had taken from that last time she saw Paul in Butaro. In her message, she said, The beautiful thing is that in these last few weeks in Rwanda, Paul was able to do it all. Virtually participate in his academic duties in Boston, teach medical students at UGHE, round on patients at Butaro Hospital, and spend his afternoons planting redwoods and roses. It was such a gift. The photo she sent was taken when Katie was tasked with finding him, since he was running late for somewhere he needed to be. When she turned the corner to where she knew Paul was, she saw him climbing up the hill with the view of the Muhabura volcano in the background, and he had his arms outstretched wide. She started to laugh and said, "Who do you think you are, Julie Andrews?" Katie then called to him to congratulate him on all he had done to make his dream of a medical school in rural Rwanda a reality. She told him, "You did it." Paul quickly replied, "No, we all did it, and it's just the beginning." And so it is. Thank you. And thanks to Professor Jenkins for this brilliant memorial to Dr. Paul Farmer. That leads us to today's keynote speaker, Dr. David Grelotti, psychiatry at UC San Diego. He completed medical school at Johns Hopkins University School of Medicine and his residency in adult psychiatry and child and adolescent psychiatry at Harvard Medical School. He served as the inaugural Dr. Mario Paganel Global Mental Health Delivery Fellow at Harvard Medical School and Partners in Health, working in Haiti and Southern Africa. He subsequently completed an NIMH-funded postdoctoral fellowship in psychiatric epidemiology at the Harvard School of Public Health. He directs mental health treatment services for people with HIV at UC San Diego's Owen Clinic and conducts research at the intersection of mental health, substance use, and HIV prevention. Please join me in welcoming Dr. David Grelotti.
Thank you very much, Dr. Shortash. I am very privileged and humbled to be honored as the keynote speaker here. But I feel like the honor is worthy because we'll be talking about Paul Farmer and some of his legacy, some of his many, one of his many legacies. And it's interesting, Dr. Jenkins' more personal kind of notes about him were just so heartwarming. Really, I think gives you like a great view of the man. And I wanted to actually spend a little time on the work and the work inspired by him, the work that was really certainly only possible because of all the people that kind of worked in this area with us on it, but wouldn't have been ever taken place without him. And so, so I titled this talk, Paul's Pearls. I got to interact with Paul Farmer in the context of my work at Partners in Health, which is right after completing my residency and right after the earthquake in Haiti in 2010. And then subsequently, when I was at the Harvard School of Public Health, I got to have the privilege of being an apprentice to teach this global healthcare delivery course at the Harvard School of Public Health that was co-taught by Joe Radigan, Joya Mukherjee, and Paul Farmer. And it was actually one of my conversations with Paul during that course that inspired the title for this talk. And I had taken the course before and had heard him talk many times. in the context of some of the work that we did in Boston, but also even in Haiti as well. And after his talk, Ophelia Dahl was also in the audience that day, and I went up and said hi to her because I hadn't seen her since I worked at Partners in Health. And Paul Farmer came up to us and he apologized to me. He said, "David, I know you've heard this talk a couple of times, and I just sat up there and I was thinking, my gosh, you must be so bored. I should have done something different for this course." And I said to him, like, "Are you kidding me?" Like every time he told the story, even if parts of the story were the same, his thinking about it would change. It was very dynamic, and I was always able to find pearls out of any time I had an opportunity to hear him. And I said, you gotta keep talking, and even if you're telling the same stories, because I'm saving up these pearls for a necklace. And so we had a pretty good laugh, and Ophelia Dahl also kind of reinforced the whole kind of pearls notion. But at the end of the day, I think, here we have Paul Farmer, who was like a brilliant guy, and whose thinking has really kind of changed the world, showing a vulnerability that I think also just made being able to interact with him all the more precious. But it's interesting. My ability to work with Paul Farmer and Partners in Health was really a result of the 2010 earthquake in Haiti. And it was a terrible kind of opportunity to get involved in this, in his endeavors. And with the earthquake, it was made possible because with the earthquake, there was a great expansion of the Partners in Health mission because of the amount of support that had come to Haiti to help rebuild after the earthquake. And it was an interesting thing to be a part of, since my organization, Partners in Health, had been working in Haiti for years. And we had a recognition that a lot needed to be done in Haiti before the earthquake. And also this idea that if some of that work and some of that, even some of that funding had come before, the earthquake may not have had such a significant impact as it had when it happened. And Paul Farmer described this really well in his book on Haiti after the earthquake, that the earthquake can be understood as an acute unchronic event. It was devastating because a history of adverse social conditions and extreme ecological fragility primed Port-au-Prince for massive loss of life when the ground began shaking on January 12th. And there was a great humanitarian response. And most of it was geared toward disaster relief. And I don't want to belittle disaster relief. It's really important. Certainly, there was a lot of acute needs that occurred after the earthquake. But Paul Farmer really had talked about how there were that these conditions were that adverse conditions were occurring before the earthquake, and were also really important to address and to continue to address once roads had been rebuilt and injuries had been mended. Some of that work actually came in the context of our mental health work. And so certainly there was a belief that after the earthquake, a lot of people would be experiencing a lot of mental health problems as a result of the trauma and loss that they had experienced. And we, in addition to other groups, had found high rates of depression and post-traumatic stress disorder, which is an anxiety-related disorder that can occur after a traumatic event, like a natural disaster. We found high rates of these conditions amongst various populations. We focused on Haitian youth in the Central Plateau. Many of the youth actually had been relocated after the earthquake from Port-au-Prince to the Central Plateau. But there were other groups working in different parts of Haiti, found very similar things, but few groups were actually looking at, trying to understand the high rates of depression and PTSD in these communities. And indeed, what we found was that a lot of people in these areas, including our youth, had experienced a wide range of stressful life events over the course of their lifetime. In fact, we did not find one youth who did not report at least one significant stressful life event. To our surprise, many of them had no longer considered the earthquake or other natural disasters that had occurred in Haiti as significant stressful life events. What they endorsed most commonly were being exposed to being part of being exposed to violence or being a witness to violence. And when we actually did an analysis to examine the association between these stressful life events and a diagnosis of PTSD, what we found was it was actually interpersonal trauma and not natural disaster that best explained why there was so much PTSD in these communities. In fact, being a witness to physical violence, to war, an armed conflict, things that actually had been occurring in Haiti for years were significant, but more significantly were sexual assault. All things which can be conceived of as the structural violence that was a part of that was part of the conditions that folks were living in Haiti that may not have been, certainly weren't improved after the earthquake. So, in addition to disaster response, we wanted to focus on healthcare system strengthening. Disaster response, typically involves going in, cleaning up, and then leaving. But we had Partners in Health had been in the community for decades prior to the earthquake, and had every intention of remaining in the community until they achieved their goal. And since things are always evolving, we didn't really necessarily see an end in sight to our presence there. But we wanted to make a difference, and a lasting, sustainable difference, and we conceived of that as coming through healthcare system strengthening. And one of the kind of driving observations, that one of the driving kind of motivations for this type of work actually was something that Paul talked about in Infections and Inequalities. He said that I had seen a lot of tuberculosis too, even though the little clinic in Dokai was built to serve only a tiny region of the Central Plateau. The doctor in me insists that no one should die of tuberculosis today. It's completely curable. In the context of global mental health, what we're talking about may not be conditions that are curable per se, but certainly when you think about most mental and neurological disorders like depression and epilepsy, they're treatable, they're manageable. These are conditions that actually confer great vulnerability to disability in communities. They're highly disabling conditions that make it hard for communities to thrive. And there is throughout the world a challenge to access to care, but a challenge or gap to treatment, mental health treatment gap, that is much more pronounced in low and middle income countries and other resource limited settings like Haiti. So filling that gap also poses a challenge, and that's where we kind of set our sights. My first month in Haiti actually occurred when I was a resident. It was after the earthquake, but they were gearing up at Partners in Health to launch a fellowship, which would actually have a psychiatrist actually work in country with the local mental health team to expand and develop services that would always be there. And so in March of 2011 was my first trip, and we published the results of kind of what we saw when we were there. Essentially, at the time, the Partners in Health system in Haiti, Partners in Health in Haiti is actually known as Zami La Santé. They had a non-specialist psychologist, so somebody who had graduated from university with a undergraduate degree in psychology. They were stationed in our local health clinics doing mental health care, almost exclusively forms of psychotherapy. But there was a great need to do more kind of psychiatry as well, which would involve more capacity to do comprehensive evaluations for mental and neurological conditions, and if appropriate, to also prescribe treatment. And our first month, in my first month there, basically went to different clinics, we would hang out a shingle, say the psychiatrist is in town, come around if you want to chat. And we also did this through some very, very interesting, very fun radio advertising. I'm going to try and play this. I hope you guys can hear it.
Département psychosocial et santé mentale, Zami La Santé Semac, a fait tout le monde qui est intéressé connaît que sorti 16 mars pour arriver 20 mars 2011, il y a un spécialiste psychiatre américain qui a organisé consultation clinique et bail prescription pour tout le monde qui a un problème mental.
So that was just a short snippet of a radio ad that was played on the radio waves in Haiti, like letting people know that I would be at the local health clinic offering free services and partnering with the local mental health clinician there. And I love it because it's the first time I ever saw psychiatry portrayed in the same way I might think of a monster truck rally. But in any event, what we found in our first month, we had a lot of people come by. And they had very common mental health conditions that were easily treated, but what was uncommon was that people had rarely actually had treatment for these conditions previously. And this is occurring, there were several kind of challenges, and this is actually another group that was working in the Central Plateau at the time. Actually, Dr. Kaiser from UCSD was a part of this group. They have been working with healthcare providers in a different part of our province, and showed that a lot of people were actually coming for care at the local health clinics and describing complaints that may have represented mental health problems. They were ways of kind of expressing their mental health problems. It's called idioms of distress. So they might say that their heart was tight, or they were thinking too much. And sometimes they would, also describe like physical symptoms like headache and such. And many of these folks would actually leave the clinic without a assessment of their psychosocial health, but rather like a prescription for Tylenol or ibuprofen. And Haitian physicians at the time didn't feel like they were equipped to really deal with the psychosocial problems, although they did recognize that many of these things that folks were complaining of represented mental or neurological disorders. So one of the things that we wanted to do was find a way of actually screening for these conditions. And in this case, we looked at, we were focusing on depression. And so we captured all of these idioms, distress on cards, and then had local experts, both natural healers, the clergy, and local professionals like psychologists and such, sort the cards into symptom clusters and see, like, well, if somebody has this complaint, what other symptoms are associated with it? And essentially, we found that there were three main categories of complaints. So psychosis and psychotic disorders, anxiety-related complaints, and depression. When we took the depression complaints together, we then we put together a kind of a preliminary screening tool and gave all these questions to folks who were depressed, and then a group of folks who were not depressed, and found out which items were the best, that best captured depression in this community. And we came up with a 13-item depression screening tool that we then later leveraged into other programs. And here's where I want to kind of bring in something that Dr. Jenkins mentioned about Paul, something that I think is actually best kind of captured in the Haitian proverb, "Main pile chai palu," basically many hands make for light work. But Paul wrote, with rare exceptions, all of your most important achievements on this planet will come from working with others, or in a word, partnership. And we had a screening tool. We had psychiatric medication. What we needed were people who were able to kind of put a plan together that actually was going to make a difference in communities. And that's where we started thinking about how do we strategically build a team that can do mental health care, recognizing that it can't all be done by psychiatrists. I was the only psychiatrist for 1.2 million people. And it's like a tall order for any psychiatrist. But we had community health workers. They could administer screening tools. They could actually do some brief forms of psychotherapy. We had our psychologists who could actually be trained and did very well in training for more intensive forms of psychotherapy. And then as pictured in my picture here are two of the physicians that I worked with that learned how to become basically specialist prescribers for mental and neurological disorders. Some of it was hard because we didn't have a lot of tools other than our ability to interview patients and observe, and then a few labs. But some of it was easy because although we only had 11 medications on our formulary, 11 psychiatric medications on our formulary, we actually could do a lot with those medications. And then I myself and a number of other folks could serve as like supervisors. We didn't have to be necessarily in the country all the time because you could call and do some supervision there. We put it all together. We had a very elaborate system for making sure we found people with depression and got them better, using the screening tool as a guide for telling us what level of care they need, using our people to actually make sure the care happens and make sure people stay safe in that context. But as more we did this, the more we learned, well, maybe it's just not enough. We were finding that people that we would work with community health workers, we would get people who sometimes it was hard to get them to come back. And one of the things that Paul kind of talked about was the need for flexibility and for an understanding of what's going on. That's often beyond what a traditional kind of physician might think. And so here's from Pathologies of Power. Certainly patients may be non-compliant, but how relevant is the notion of compliance in rural Haiti? Doctors may instruct their patients to eat well, but the patient will refuse if they have no food. They may be instructed to go to the hospital, but if hospital care must be paid for in cash, as is the case throughout Haiti, and the patients have no cash, they will be deemed grossly negligent. So we were finding that, yes, okay, we were going to be able to find people with mental disorders. We're going to be able to diagnose them. We were actually doing a pretty good job of linking them to care. But for some people in communities that were actually not, even though our clinics were actually in very rural areas, there were still people who lived very far from these rural areas and had very limited means to actually get to us. So we wanted to think about how do we get them the care that they need. And we developed a mobile clinic to actually get to them. And our first mobile clinic was in January 2012, about 6 months after I started living there full time. We had the community outreach. We brought a pharmacy with us. We were giving free medication. We marshaled all of our non-specialists to kind of convert to use this converted church as a makeshift psychiatry space. And we found that we were getting a lot of people coming in with mental and neurological disorders. And we were doing a better job of getting them back. It's not a perfect job. And I think there's another quote that I was meant to actually add to this, that it's hard to actually be perfect in the setting. And sometimes like getting your foot on the ground, starting to do the work is a great way of actually getting momentum to start doing the work better. Anyway, one of the unintended consequences, I think, of this whole endeavor was how much of a community event our mobile clinic became. And this is from one of the community health workers who works in this area and partnered with us on this project. But he wrote that he said to us in an interview, which is part of our publication on this clinic, they would stigmatize people like those who have epilepsy. Myself, when I didn't yet have information, hadn't been trained, when they would fall during a seizure, I was afraid to touch them. Now I'm not afraid. Paul often speaks about how, sometimes like communities are actually socialized into scarcity, that the conditions actually create an environment where they can't believe that people can get better. They have other, it becomes like sometimes instead of like generosity, it becomes like there's a suspicion. And I think when you kind of get on the ground and start showing folks a different way, getting people better, treatment is stigma reduction. Treatment is actually public health. So I just want to round out with a couple other things that are very clear from some of my conversations with Paul. We were talking once about some of the accompaniment work that Partners in Health really was one of the first kind of originators of. And we see it now as peer navigators in many of our kind of local clinics. But it took a while for people to come around in this community to learn from things that were being done in global health. And Paul Farmer was a firm believer that the things that people have done in global health actually might actually be very helpful in local health. He kind of remarked in Infections and Inequalities, our society ensures that large numbers of people in the United States and out of it will be simultaneously put at risk for disease and denied access to care for it. So, what do you kind of take? Well, what do I take from my time with Partners in Health and Paul Farmer? Well, there's a lot, and there's a lot of kind of stuff that I really feel privileged to having had the chance to know him, and was just devastated by his untimely death. But essentially, like he's been a real inspiration. I work with. I want to make sure that my kind of belief in academic medicine has been mostly because in that context, I can make sure that both the poor and the rich have access to the best care and the same care. There's equality and justice in the work that we do. And so making sure that the poor are included in your business plan and that you really respect the people and community and what you're doing is really something that it was not necessarily a common thought in medicine, but something I think that Paul Farmer helped make a shift toward. The other thing that I liked about Paul is like he was on the ground. He was at every level. He was treating patients. He was learning the system. He was getting to know people at the top. I mean, he was friends with the president of Rwanda, and like Bill. I have this great story about him, Bill Clinton, and Matt Damon. It's important to think about both top-down and ground-up approaches to improve healthcare. You can be much more effective if you kind of have a sense of both. Of course, partnerships and leveraging research to meet local needs. One of the things that sometimes kind of comes up when they talk about Paul Farmer is this hermeneutic of generosity. I have used that in many, many different settings where you kind of have this, like, the hermeneutic of generosity is just this, or H of G is this idea that just the people you're working with, because they're trying to do something good. And if you actually approach them with the idea that they mean well, you actually can create a common ground that might actually help you bridge a lot of barriers that you have or disagreements that you might have in how to do it. And so when there's whenever there's like in some of my international work, especially, but even in some of our clinic work, whenever people are kind of having trouble coming up with a consensus about something, And, and people seem to have chosen sides. I often bring this up, and I almost find it universally like well received as a way of kind of maintaining partnerships, reminding people we're all kind of working toward the same good end. And I know Dr. Jenkins mentioned this, Dr. Shorthouse mentioned this, like Paul was a moral compass for so many. He really like practiced what he preached. He walked, and if I could just recreate part of that, I knew I was going in somewhat in the right direction. And so I really was, and it really serves as a role model for so many. And I don't think that's going to, and we're fortunate that so many people had connections with him, and he's left such a legacy, both in human resources and in written resources. So I just, something that Paul said, and this is a before and after picture for me in Haiti, and just one of our patients who just did so well, had never been treated for epilepsy before, and then just became like this is like a Pinocchio story. He became a real boy after we just got him basic treatment. But essentially, Paul would say, like, we've taken on major health problems of the poorest: tuberculosis, maternal mortality, AIDS, malaria, and mental health in many countries, not just 4. This was an old quote. We scored some victories in the sense that we have cured or treated thousands and changed the discourse about what is possible. So it would not be a good talk about Paul Farmer if you didn't try to acknowledge everyone, and even go up and try to introduce yourself to everyone who's like present. But there are so many people who have participated in this work that I've reported here in Haiti and the United States, really like equal partners, and all trying to kind of aspire to do the best for both like the people in our communities, and also kind of to change like the way people do things throughout the world, especially around mental health, and then the other conditions that we were working in. So thank you all. Thank these guys all. Thank you all for listening. I really am grateful to have had this opportunity.
Thank you very much, Dave, for sharing, for actually weaving together a moving personal tribute with a presentation of the work that Paul achieved in his life, and not just weaving together the tribute and the work, but showing how the legacy of his work is probably itself the best tribute that we can pay to Paul. As people we're going into the last 10 minutes here of a question and answer session. And as you type in your questions, let me also make sure that you know that the extra credit Google form has been posted in the chat if you're receiving extra credit for this event for any of your courses.
Well, there is a question. I'm happy to try to take it. Dr. Short asked, Brittany Wright posted a question in the chat. In light of Mental Health Month, what do you wish more people understood about their own mental health? What can the average person do to help erase stigmas around mental health? And to be honest, like that's a really tough question. I think like the pandemic, one of the things that I've talked about with regard to pandemic stress is that in the same way, like we talked about the earthquake in Haiti, and we have data that shows like there's a great excess of anxiety and depression related to COVID-19. We were under a lot of stress even before the pandemic, and to me, like one of the things that I want people to know is that even though a lot of our interventions are going to be focused on them individually, and maybe you may not need medication, maybe like some of the different kind of mindfulness or other kind of relaxation techniques or things that would be very helpful for you. It really would be useful to think about changing some of the structures around us, which are actually contributing to stress. And, people describe the politics, our politics right now, gun violence, some of the different things that they see in the news media, all as things that are contributing to how stressed out they are. These are things that the kind of social and justice movement as it relates to inequalities and racial and ethnic disparities. Those are all things that if we were able to kind of make a dent in, it would have an improvement in our mental health as well. And even though, like, again, you might go and reach out and talk to a counselor, or go talk to a psychiatrist and get individual help. I think it's important to realize that a lot of the stuff around us is actually contributing to the problem. And as far as stigma goes, like we've looked into stigma reduction as a kind of academic, as something that we want to kind of introduce as a kind of intervention. So we review the academic literature for those types of interventions and haven't really found much. But I think like what we actually did demonstrate, and I wish we had tried to capture this some way, is treatment is actually stigma reduction. When we went into communities and started treating folks, they didn't come with they didn't come to us with the patient, like people who had mild problems. They were coming to us, the people who honestly many of whom had been chained in their homes because they had not ever had real access to mental health care. And we could do a lot to actually improve to treat them and improve their conditions. And once we started doing that, the word got out and more people came. And so it was our goal, I think, to create treatment-resistant depression. So like we wanted people to be treated for depression, come back for more, because in this country, it's actually not necessarily that easy to do. But for us, we were starting from scratch for most of these folks, and it was actually just doing it and doing it well. And I think that actually was probably the best strategy for reducing stigma toward mental health conditions. And I tell you, people would start talking about it and in their communities in ways that I was actually quite surprised by, and moved by.
Okay. We have a question from Dr. Lillian Walkover, who is a member of our Global Health program faculty and actually teaches our course on community health workers. And she's asking, how do you hold onto a hermeneutics of generosity when working in conditions that often pit people and resources against one another, both within and beyond the US?
So, I tell you, this is where it'd be really great to have Paul Farmer, because that's the person who needs to answer this question. And I have a very juvenile kind of view of it. And I just find that and it's one of the hardest things I think to hold on to is this hermeneutic of generosity, because, if you kind of, when I'm a clinician in the hospital and, we're trying to get something done for a patient, I admit I'm not always the most generous of spirit. I just want to make sure people get what they need. I think though that there's a recognition, like the recognition that you're working in an area where there's scarce resources. And one, I think Paul Farmer would be like, the notion of scarcity resources is actually a fictitious one. You would probably first, in a kind of his arguments say, let's put that aside and let's focus on, kind of the reality sometimes that we have to work in these conditions. I almost find like it's like a fire extinguisher, this idea of hermeneutics of generosity. If you are reminded of it in time, you can actually bring it out. And if there are conflicts, if there is like a dispute over these limited resources, you can actually kind of bring that in as a third person in the room and realize it might be it itself is the reason why there might be some more dispute between you. And then you can then build a bridge to actually work together toward finding a solution that actually meets both of the kind of goals or motivations that you have in the work. So that's so I don't think that's a particularly straightforward answer, but essentially I think just trying to think of it that way might actually be a helpful way of starting a conversation about some of those challenging decisions that you have to make with resources.
Thank you. I am looking at the time and I'm seeing we have only enough time now to wrap up. I'd like to thank Dr. Grelotti and Professor Jenkins for their moving presentations. And for the ending here, let me turn it back to Erin.
Thank you, Dr. Shortash. Thank you so much for being our MC today, just as I'm resharing my screen here. And thank you for all that you do for the program as well, Dr. Shortash. And we wanted to give one more thank you to all of our speakers and all of our student presenters from the Honors Cohort and all of our co-sponsors for making this event possible. Again, congratulations to the Honors Cohort students. I'm so honored to have worked with such amazing students over the last 2 or 3 years, some of you, and I'm proud of all that you've accomplished and everything that's to come in your future. As a reminder, the extra credit form is posted in the Zoom chat. Thank you all for attending. Have a wonderful rest of your afternoon. We look forward to seeing you at future events. Take care.
Thanks, everyone.